Hi, my name is Rebecca Harrison, and my project is on Marfan syndrome. About 1 in 5,000 people have Marfan syndrome, regardless of gender, race, or ethnic group. About 3 out of 4 people with Marfan syndrome inherit it through a genetic mutation from a parent who has it. It can, however, occur as a spontaneous mutation, making some people the first in their family to have Marfan syndrome. This occurs in approximately 25% of all cases. If an individual is affected by Marfan syndrome, there's a 50% chance that they will pass along the genetic mutation each time they have a child. Marfan syndrome is a genetic disorder affecting the connective tissue. Connective tissue is what holds the cells, organs, and tissues together and plays an important role in growth and development. Connective tissue is comprised of proteins. The exact cause of Marfan syndrome is a mutation in the gene that produces fibrillin 1 or FBN1. The mutation results as an increased production of a protein called transforming growth factor beta, or TGF-beta. Increased production of TGF-beta causes problems in connective tissues throughout the body, which in turn creates the features and medical problems associated with Marfan syndrome and some related conditions. Since connective tissue is found throughout the body, Marfan syndrome can affect many different parts of the body. The connective tissues of the heart, blood vessels, bones, joints, and eyes are most often affected. Lungs, skin, and nervous system can also be affected. Intellectual defects are not associated with Marfan syndrome. People are born with Marfan syndrome and its related conditions. Features of Marfan syndrome and related disorders can appear at any age. Some people have many features at birth or as young children. Other people develop features as teens or adults, and other features are progressive. Therefore, it is very important for people with Marfan syndrome and related conditions to have ongoing monitoring. This is especially true for life-threatening aspects of the condition. Accurate and early diagnosis helps to ensure proper treatment. No one has every feature and may have different combinations of features called variable expression. Some features of Marfan syndrome are easier to see than others. These include the long, narrow face, ectopia lentis, myopia, retinal detachment, early glaucoma, early cataracts, narrow palate, crowded teeth, aortic regurgitation, mitral regurgitation, mitral valve prolapse, congestive heart failure, tricuspid valve prolapse, premature calcification of the mitral annulus, aortic root dilation, aortic dissection, ascending aortic aneurysm, pulmonary artery dilation, pneumothorax, pulmonary blebs, pectus excavatum, and scoliosis. More than 1,000 FBM pathogenic variants may cause Marfan syndrome or related phenotypes. Nonsense, friendships, splice site, and missense changes have been reported. A variant that causes the in-frame loss or gain of central coding sequence through deletions, insertions, or splicing errors is associated with more severe disease. Pathogenic variants that create a premature termination codon have been associated with clinical presentations that range from mild to classic Marfan syndrome. FBN1 is an extracellular matrix protein that contributes to large structures called microfibrils that are found in both elastic and non-elastic tissues. They participate in the formation and homeostasis of the elastic matrix. In matrix cell attachments, the possibility in the regulation of growth factors. Studies in animal models of Marfan syndrome have demonstrated that microfibrils regulate the matrix sequestration and activation of the growth factor TGF-beta. Excess TGF-beta signaling has been observed in the developing lung, the mitral valve, and the skeletal muscle of the dura and the ascending aorta. The pathogenesis of Marfan syndrome is complex. Abnormal forms of FBN1 are believed to have dominant negative activity. In affected individuals, the residual level of protein is generally far below the 50% level predicted by the presence of a wild-type copy of FBN1. A hallmark feature of the Marfan syndrome is a severe reduction of microfibrils in explanted tissues and in the matrix deposited by cultural dermal fibroblasts. Marfan syndrome and related disorders can also be caused by loss of function alleles, demonstrating a haploinsufficiency mechanism of disease. Chromosome 15 likely contains 600 to 700 genes that provide instructions for making proteins. These proteins perform a variety of different roles in the body. The following chromosomal conditions are associated with changes in the structure or number of copies of chromosome 15. 15q11 to q13 duplication syndrome, 15q13.3 microdeletion, 15q24 microdeletion, acute promyelocytic leukemia, Angelman syndrome, Prader-Willi syndrome, and sensorineural neurodeafness and male infertility. Other changes in the number or structure of chromosome 15 can cause intellectual disability, delayed growth and development, hypotonia, and characteristic facial features. These changes include an extra copy of part of chromosome 15 in each cell, a missing segment of the chromosome in each cell, a circular structure called chromosome ring 15. A ring chromosome occurs when a chromosome breaks in two places and the ends of the chromosome are fused together to form a circular structure. Dietz et al. Demonstrated the first fibrillin mutation in a patient with Marfan syndrome, thereby completing the proof that Marfan syndrome is caused by mutations in the fibrillin locus on chromosome 15. Marfan syndrome is inherited as an autosomal dominant manner. About 75% of those diagnosed with Marfan syndrome have an affected parent. The other 25% with Marfan syndrome have the disorder as the result of a de novo pathogenic variant. Both parents should be evaluated for manifestations of Marfan syndrome by performing a comprehensive clinical examination and echocardiogram. If the FBN1 pathogenic variant has been identified in the affected individual, molecular genetic testing to clarify the genetic status of the parent is possible. If the FBN1 pathogenic variant found in the affected individual cannot be detected in the leukocyte DNA of either parent, possible explanations include a de novo pathogenic variant or germline mosaicism in a parent. Germline mosaicism has been reported in rare cases. Although 75% of individuals diagnosed with Marfan syndrome have an affected parent, the family history may appear to be negative because of failure to recognize the disorder in family members or early death of the parent before the onset of symptoms. The diagnosis of Marfan syndrome is established in a person who has an FBN1 pathogenic variant known to be associated with Marfan syndrome and either aortic root enlargement or ectopia lentis. When the clinical findings suggest the diagnosis of Marfan syndrome, molecular genetic testing approaches include single gene testing or use of a sequence analysis panel. In single gene testing, sequence and deletion duplication analysis of FBN1 is performed. Approximately 5% of all Marfan syndrome diagnoses are derived in this way. Sequence analysis detects variants that are benign, likely benign, of uncertain significance, likely pathogenic, or pathogenic. Pathogenic variants may include small intragenic deletions, insertions, and missense, nonsense, and splice sites variants. Typically, exon or whole gene deletion duplications are not detected. Approximately 90 to 93% of all Marfan syndrome diagnoses are derived in this way. To establish the extent of disease and the needs of an individual diagnosed with Marfan syndrome, the following evaluations have been recommended. Evaluation by an ophthalmologist with expertise in Marfan syndrome, including slit lamp examination through a maximally dilated pupil for evidence of lens subluxation, refraction and correction of refractive errors, especially in young children at risk for amblyopia. Specific assessment for glaucoma and cataracts. Evaluation for skeletal manifestations may require immediate attention by an orthopedist due to the association with scoliosis and pectus excavatum. Surgical intervention may be required. Echocardiography with focused evaluation of aortic root measurements must be interpreted based on consideration of normal values for age and body size. Selected findings may require the immediate attention of a cardiologist or cardiothoracic surgeon. The biggest management factor with individuals with Marfan syndrome is aortic dilation management. It has been suggested that beta-adrenergic blockade might reduce the risk of aortic dissection in patients with Marfan syndrome. Use of beta blockers has shown a significantly slower rate of dilation of the aortic root and improved survival with fewer treated patients reaching a clinical end. Consideration of instituting beta blockers at an early age is necessary with a Marfan syndrome diagnosis. Surgical repair of the ascending aorta is recommended for patients with moderate aortic regurgitation or marked dilation of more than 5.5 centimeters in diameter of the aortic root. Judicious use of subacute bacterial endocarditis prophylaxis is indicated for dental work or other procedures expected to contaminate the bloodstream with bacteria in the presence of mitral or aortic valve regurgitations. Patients with Marfan syndrome are advised against contact sports due to the possibility of impact injury to the chest. Any physical activity that can cause joint injury or pain is also advised against. Lastly, any agents that can stimulate the cardiovascular system, including routine use of decongestants, energy drinks, and caffeine. Currently, the largest consideration to be made with a Marfan syndrome patient is the risk of pregnancy. All female patients with Marfan syndrome who wish to become pregnant would be considered a high-risk pregnancy. However, due to the high incidence of cardiovascular complications with Marfan syndrome, women are advised against pregnancy due to the stress it places on the cardiovascular system. If a female Marfan syndrome patient decides to become pregnant, delivery should be as stress-free as possible and childbearing should be done early in life. Certain medications cannot be used due to the risk of birth defects and fetal death. There are currently 3 studies, including recruiting regarding the study of Marfan syndrome. The one study in France is studying the effects of physical activities and training in relation to Marfan syndrome. The other 2, which are being conducted in California, look at the effects of Marfan syndrome in children. All 3 of these studies are currently recruiting subjects. Marfan syndrome is a rare disorder. Practitioners will not see Marfan syndrome very frequently during their practice. Predictive testing should be done for at-risk asymptomatic adult members for the FBN1 pathogenic variant. Genetic testing should be done prior to pregnancy, and genetic counseling should be offered at that time. At-risk adults should be tested using sequence analysis or gene-targeted deletion duplication analysis. These are my references, and thank you.